Hello, and welcome to CQC Connect, the podcast from the Care Quality Commission. My name is David Gwyther, and I'm a Communications and Engagement Manager here at the CQC. Today, we are going to be talking about a long-standing concern in the primary care sector, and that is that GP practices managed and/or led by people from a Black, Asian, or ethnic minority background are more likely to receive lower ratings from the CQC and may disproportionately face more challenges in meeting their legal or commissioning requirements due to factors outside of their control. The CQC has started a project to investigate this concern. To discuss this topic, I am joined by Dr. Ayisha Ashmore, National Medical Director's Clinical Fellow here at the CQC, and Joint Project Lead on the CQC's Inequalities Project. I am also joined by Dr. Faizan Ahmed, National Clinical Advisor for the CQC in Primary Medical Services and Integrated Care. Ayisha, if we can start with you, how did this project come about and what exactly will it entail?
Hi David, thank you so much for inviting me to this podcast. It's really an exciting opportunity to talk about the project that we're doing. So I think the first point I want to make is actually the CQC had already been investigating some of the concerns prior to being contacted by the Royal College of General Practitioners. One of our inspectors, Annabelle Stigwood, had already started to investigate the experiences of general practitioners who were placed in special measures by the CQC in their inspections. And prior to that, we had already done some work looking at the differences in inspection outcomes based on the place of primary qualification of a general practitioner. But we know that this was really a proxy indicator for ethnicity. And as a result, we wanted to further the work that had been done with this new project looking at ethnicity specifically. So as a lot of you may know, the Royal College of General Practitioners had written to the CQC regarding concerns that ethnic minority general practitioners had different outcomes from CQC ratings than non-ethnic minority general practitioners. And really, this is where this project, the GP Inequalities Project at CQC, begun. So we kind of have a three-pronged approach to this project. So first of all, we really want to understand whether there actually is a difference in the ratings between the two different ethnic minority and non-ethnic minority groups. And the way that we wanted to do this is look at it quantitatively, looking at the statistical numbers between the ratings between the different groups. And what we wanted to do is work collaboratively with the GMC to match their ethnicity data that they hold for all doctors in the UK with our CQC rating data. And we've worked really closely with them to try and get this data. And luckily in July, we did manage to get hold of this ethnicity data. But since then, things have progressed and this project has really progressed at pace. And unfortunately, at this point, we're unable to use the ethnicity data that they've been able to share with us in any modelling that we were planning on doing at this stage. But that's not to say that this won't be able to be possible in the future. So that was the first part. The second part was really about understanding perceptions, because even if there was or was not a statistical difference in outcomes, there is a perceived difference in outcomes, and that's why this concern was raised. And in order to do that, we wanted to speak to GPs themselves about their experiences of the CQC in their inspections and their regulatory outcomes. So that's the second part to answering that question. We also understand that the CQC doesn't work in isolation. We work as part of a system, and it's multiple factors that interact with each other which eventually leads to differential outcomes. And these factors may be environmental, for example, the deprivation level of an area, the funding that an area receives, etc. Factors within the GP practice itself. For example, if a GP practice is single-handed, which means that they're run by one GP partner by themselves, whether they're a training practice, whether they have different list sizes, different patient to GP ratios, etc. And lastly, the CQC itself. So what are our policies? What are our methods? And does that lead to different outcomes between the different ethnic groups? And actually, how do we handle our complaints and factual accuracy checks? And are there themes that arise between the different ethnic groups? And these are the kind of things that we wanted to investigate. A part of that is also looking at our own internal diversity data to see whether the CQC inspectors and our teams, are they representative of the GP practices and the populations that they serve. The last part of our project is really about looking forwards and looking at improvement. We want to know what support is available for GP practices that may be struggling and what support is there to navigate these processes, which can sometimes be a little bit tricky to get through. So what we want to do is understand what support is available, and actually, is that support adequate, and is there anywhere else that GPs would like support from? And I think that would take this project into the next stages and help drive improvement, not only for the GP practice, but also for patients and the quality of care that they receive.
Thank you, Ayisha. Faizan, if we can come to you next. Why is it important that the CQC is undertaking this project? And what does it mean to the CQC as a regulator?
Hi, David. Thank you for the opportunity to discuss this most important matter, certainly in the context of the challenges that the health and care system is facing at the moment. It's important that the due importance of such an issue isn't watered down in any way. And just reflecting on the comments that Ayisha's already made as an organisation, as the independent regulator of health and social care in the country, the public expect us to do the right thing, and this is very much a critical element of doing the right thing. Our public expects to have confidence in the independent voice that we provide, and that independent voice can only be firmed up if the people, the organisations and the services that we're regulating have that same confidence in us as individuals, in our processes, and within that fairness and compassion in everything that we do. And just taking that word compassion, I think too often we use that as a bit of a soundbite in terms of values of an organisation, but genuinely that's where we are as a committed group of people. And I can say that from our executive team right through to our inspection teams, we are absolutely committed to getting this right. It's important, and as Ayisha so rightly says, that we can't do this alone. It's very much a systemic issue, and I've often reflected that the adverse outcomes of these inspections are very much an end point of multi-layer, multiple system failings. And so the ownership of the wider work in relation to this must sit as a collaborative effort. And Ayisha's mentioned some of the stakeholders that we have already engaged as part of this work. But it's important for us to recognise that this isn't purely a primary medical services issue. It affects our social care system and our hospital system as much, if not more, across the piece. And so taking that baton on, I can firmly say that our inspectorate leads have already engaged with key stakeholders, and those stakeholders critical in this state of flux that the health and care system finds itself in, being NHS England Improvement and associated bodies across the general practice sector. But what's important is not to forget our social care colleagues, particularly the local authorities. And it's important that the whole out of hospital system is geared towards tackling this together and in a meaningful way that will make an impact ultimately, not just for the providers, but the patient experience and the service user experience.
Thank you, Faizan. Ayisha, what are the outcomes that the CQC hopes to achieve through this piece of work? And what stakeholders and people with lived experience is it involving?
So I think it's quite important to state that this is very much an initial piece of work, and it's very exploratory in nature at the moment. The reason that we're doing it is to get a better understanding of these concerns and a better understanding of what factors may influence some of the things that we've heard in order to drive improvement in the future. We know that it's a very sensitive area, and we've tried to facilitate safe feedback and promote transparent discussions between GPs and ourselves. And one of the ways that we've done this is that our GP survey is anonymous. Another way is that we've asked an independent company to perform the online community, which is another way of doing focus groups, so that there's a level of independence so people feel safe to discuss their concerns and tell us truthfully what they're experiencing. And I think that's one of the outcomes that we want. We want to have honest conversations with GPs about the experiences that they've had. So the second part of the question is really about who we've engaged with. And we've tried really hard to engage with as many GPs and stakeholders and representative groups along the way, because, as I said, we want to have honest discussions. So the ways that we've done that is that we've developed an external advisory group. And this is a group made up of volunteers from representative groups of GPs. And what they do is that they meet with us once a month, and we're able to discuss with them our plans for the project, the methods that we're using, the topics that we're discussing, and they are able to quality check what we're doing and challenge us if needs be. And we are able to then adapt our processes to match their expectations, to ensure that we're meeting our objectives and make sure that we're accountable essentially to the sector. Secondly, we have a stakeholder group which is now a subgroup of the Primary Care Quality Board, and this contains some of our larger organisations and arm's length bodies, as Faizan has mentioned. So we have representation from organisations such as the General Medical Council, the Nursing and Midwifery Council, Health Education England, the Royal College of General Practitioners, the British Medical Association, etc. And what we're trying to achieve within that group is collaboration. We know that, as Faizan has said, that this is a systemic issue and that the CQC outcome is really a symptom of the problem. And by the time we get to the CQC outcome, there have been a number of factors that could have been addressed a lot earlier in the journey for a practice before the CQC gets involved. And actually, what we want to do is progress priorities so that the system works together to ensure that problems are addressed earlier on in the GP practice's journey in regulation and working within a system. And we want to progress these priorities through collaborative efforts with this subgroup of the Primary Care Quality Board. We also have consulted with external experts, so people who have lived experiences, but also are academics within the area who have been able to advise us on this project, and again to ensure that we have adequate challenge, that we've considered different factors, different influences, and that we've taken a holistic approach to our project. And lastly, we want to include every general practitioner within this country. And what we've done to be able to enable that is we've developed our own engagement platform, which in plain terms is just a website where people, as well as general practitioners, can keep up to date with our project, and we update it with what we've achieved, what our next steps are, any blogs, and this podcast should be available on it as well. So that's really how we're keeping people involved and what our aims and objectives are.
At the end of this project, what does the CQC hope to get out of it? And how do you think it will change how the CQC operates as a regulator? And Faizan, feel free to come in on that question as well.
I think that's a very hard question, David, because it's very difficult to know in advance of receiving results what we're going to find. I think what we would like to do is to have an open dialogue and to facilitate honest conversations between general practitioners and the CQC, first and foremost. Number two, we'd like to be able to use the information that we've gathered during this project to be able to inform the way that we regulate in the future, and to be able to take into consideration other elements within the system which may affect GPs.
David, I'd just add to that, and it's an excellent summary where we're currently at, described by Ayisha, and I think we already, as a regulator, expect our providers to report on the workforce race equality standard established by NHS England. But increasingly, as the health and care system moves towards an integrated model of provision, we will be looking for ways where any elements of institutional, structural, or indeed interpersonal discriminatory behaviour, there will be pathways where patients, service users, our staff across the health and care system will be able to raise issues, and listeners will be aware that the Care Quality Commission hosts the Freedom to Speak Up initiative. We've held the Health Watch remit for a number of years. And this really is about making speaking up and raising concerns absolutely everybody's business, and be able to frame that and provide that safe space. The natural home for that safe space needs to be with us as the CQC. And as Ayisha rightly says, that is very much work in progress, and we wait and are chomping at the bits as the systems start to bed down in terms of recovery post the COVID pandemic and its early shoots. Certainly, we're mindful that any process that we put in place is bureaucracy light, but is absolutely outcome driven and change defining.
Will this project form part of a greater focus by the CQC on tackling inequality? And you've mentioned just there about how you feel that the CQC is well placed to be in a position to bring about change. I was wondering if you could say a bit more about that.
Really, really fascinating space, David. We talk about health inequalities, don't we? And we talk about inequalities in the broadest sense. But what's really refreshing about our new strategy is that we're talking about equality, that the beginning point should absolutely be that any service, any provision that we are scrutinising through our inspection processes, it has to be through the equality lens. What difference is that service making, and the innovation that happens in local pockets that we just don't hear about and it's not recognised? Everybody in this country should be entitled to a standard of health and care that, whether they access it in Manchester or whether they access it in Devon, should be exactly the same. It should absolutely be individual focused, where that person, that service user, that patient genuinely feels that they're getting the very best that this country can provide in relation to health and care. As we go through this particular work stream relating to perceived and potentially apparent differences in outcomes for our providers being led by people of Black, Asian, minority ethnic heritage, it's absolutely vital that the outcomes that Ayisha refers to is a genuine product of co-design with the very people that have got a concern.
Thank you, Faizan. Ayisha, what are the next steps for this project? And is there a way that other organisations and providers and many stakeholders that we've mentioned before can take part?
So at the moment, the project is tying up. We've just completed all of our field work, which means that we've completed the kind of data gathering phase. However, this project, as I said earlier, is a very initial project and it's about understanding. But the findings from this will influence a lot of the work that is done within the system, I hope, for a longer period of time. And I think that the crux of this is the collaborative working. And in order for that to progress, what we need is for the organisations within the system to work together as part of the subgroup of the Primary Care Quality Board to progress the priorities that have been discussed within that group, to make sure that the findings from this are taken forward and are acted upon in a way that can be delivered in outcomes to GP practices which are led by minority ethnic doctors.
Do you know when the project might be ready to give initial findings?
So without getting into too much trouble, we can probably start to share some very early snippets in the next few months, but we're hoping to have a report ready by Christmas.
That sounds great. And we hope to have you both back on the podcast when we have those initial findings to discuss what they might be. Well, that's all the time that we have for today. I would like to thank my guests, Dr. Ayisha Ashmore and Dr. Faizan Ahmed. You can keep up to date with the project at cqc.citizenlab.co. Just follow the link in the podcast description. Until next time, thank you for listening.